All right, folks, good afternoon. My name is Erin. My pronouns are they, them, and I'm with Project Echo. Welcome to the Public Health Science Echo, where the public has the opportunity to ask science-based questions for our public health team.
Okay.
For those of us joining on Zoom, questions may be entered into the Q&A feature. And for those of us joining on Facebook, please add your questions in the comment section and they'll be shared with our panelists. As a reminder, we expect all participants to keep questions and comments on topic, to be considerate, and to use language that is respectful. So for that, we thank you. I'd also like to note that the opinions expressed in this session are those of the speakers and do not necessarily represent those of UAA, DHSS, or any of our ECHO sponsors. We'll now proceed to introduce the State of Alaska Hub team, starting with Dr. Zink.
Hi, everyone. Dr. Ann Zink, Chief Medical Officer for the state. Thanks for being here.
Thank you so much. And Dr. McLaughlin, please.
Oh, hi, everyone. Dr. Joe McLaughlin. I'm the Chief of the Alaska Section of Epidemiology and the State Epidemiologist.
Thanks so much. Dr. Castrodale.
I am Louisa Castrodale. I manage the infectious disease program here at the Section of Epi. Thanks.
Thank you. And Elizabeth, please.
Yeah, Elizabeth Manning, DHSS Communications Manager. Hello, everyone.
Hi, thank you so much, Elizabeth. And Teresa and Michael.
Hey everyone, I'm Teresa Savage. I'm a clinical micro lab manager here in Anchorage for the state lab.
Michael Stevenson, also here at the state lab, public health laboratory scientist.
Great, thank you. And Barb, please.
I'm Barbara Pennington. I'm a school nurse consultant with public health.
Erin, you're on mute.
Thank you. Matt, if you could introduce yourself, please.
Hi, everyone. I'm Matt Bobel. I'm the Immunization Program Manager with the Section of Epidemiology.
All right, thanks. And Dr. Cutchins.
Hey, Coleman Cutchins, Clinical Pharmacist here with the state and the State COVID Testing Lead.
Thanks. Clinton, please.
Hello, everybody. Clinton Bennett, Communications Director, Alaska Department of Health and Social Services.
All right, and last but not least, Heidi.
Everyone, thanks for joining us for another Public Science Echo. My name is Heidi. I'm the Director of Public Health.
All right, excellent. So without further ado, I'll go ahead and hand it over to the Hub team for our presentation today.
Great, thanks so much. I'll go through a few slides here, and I already see questions popping in the chat box, which is great, and then we can get to those as quickly as possible because we really want to hear from you all. Before I even start, we get a lot of emails and we get a lot of questions, and we keep directing people to the Public Science Echo. So thank you all for coming to here so that we can answer them in one place with the experts that are here. I think it's much more effective and efficient for the time. So thanks for taking the time to join us today. So just where we're at with COVID overall, we have been seeing a real increase in cases, and most of our state is in the high alert red level overall. Again, we have those cases that are resulted 3 days a week and should have the Wednesday ones up shortly. There was some new CDC announcement, which I'll go through in a minute, but the CDC has an additional dashboard. They use 4 colors instead of 3 colors. And this is kind of how the country as a whole is looking. And we'll put this in the chat box for this CDC link, but then you can look specifically at what they call county by county, but for us, it's borough level data on case rates. They use a slightly different count than we do. They do a 7-day versus we do a 14-day, and we have these kind of behavioral health regions. The reason we did a 14-day in these behavioral health regions is because we have such a sparsely populated state that one outbreak could really send you into a high red or to a low. And based on the CDC criteria, some communities would only be in the super high or super low, but they could never get into a partial one because there's just so few people in that region. But much of the CDC guidance that recently came out was in reference to their map and guidance talking about transmission level. So, each of those tools has different values to them overall, and happy to talk more about that. But I just wanted you to be aware of this CDC level guide overall. Here's where the US is and where Alaska is. You can see in general, we've had similar trends to the US as a whole, except we had a little bit of a later surge. We didn't experience the first couple waves that the US experienced in the same way. But the US as a whole is really going up in the number of cases. And you can see Alaska is very much following that trend right now. And unfortunately, we're not following it much later. We're following it kind of right on track with the rest of the US as we really are seeing a lot of Delta up here. Here's again looking nationwide at cases and trends. So again, this is cases over the last 8 weeks. And we've had, between 100 and 200 cases per 100,000 in the last 7 days and increasing. So you can see a variety of states. Every state's been going up or holding slightly flat. The areas that are the least vaccinated in this country are having the fastest rises. So Missouri, Arkansas, Louisiana, Florida are really seeing sharp rises overall. The Northeast is the region with the highest vaccine. And while they are still going up, we aren't seeing nearly the rise there overall. Vaccines continue to clearly be the way out of this pandemic and why we encourage people to consider vaccinating. And you can see where we're at compared to other states. Another thing that we look at is the testing data. Again, testing is kind of like the lights on your car, helps us to see where we're all going. Anyone who is symptomatic should very much get tested for COVID-19. Identifying these cases early and often is helpful. Remember, the airport testing is available. You don't have to go through security and you can get rapid tests there. Husband flew back in town last night and he and the kids went through the testing and got it right there in the airport just because they had been traveling. And so they know it's there, it's available, it's free and accessible for Alaskans so that they know. Again, you can see the percent positivity really skyrocketing. Arkansas, Missouri, Louisiana, and Florida at this time. Ours is definitely going up, not quite at the same rate, and want to continue to be able to see these cases early. I think that part of our success early on was having access to testing to be able to identify cases early so individual Alaskans can make the decision to minimize their spread to other people overall. Here again, you can see the test positivity in our state, and you can see that we need to be doing more testing, particularly along the road belt and in some of our places in the southeast. So we're just over 5% of our tests are positive at this time, and again, encouraging people to get tested for any symptoms. Other reasons that you may consider getting tested before a procedure, because we know that people who are intubated do better if they don't have COVID. And so considering that prior to a procedure, if your hospital or clinic doesn't require it. If you are in quarantine because you've been closely exposed to someone with COVID-19, somewhere between 5 to 7 days can be very helpful. The new CDC guidance do talk about even if you're a close contact and you're vaccinated to also consider getting tested. So we are seeing more cases of vaccine breakthrough and cases being spread from person to person who are vaccinated than we had with the wild type. We still see the vaccines doing an amazing job of protecting Alaskans overall. But with the Delta variant, there have been changes in the virus, which have resulted in changes in the science, which have resulted in changes in the messaging from the CDC and from us. So with the new Delta variant, encouraging close contacts to consider getting tested as well. Here's the percent positivity in Alaska. You can see that we peaked back in November at 9.3%, but we're having a pretty fast rise at 5.5% right now of our tests are coming back positive, higher than any other time in the pandemic except for last November overall. Here's where we're at with vaccines. I think sometimes people think that it's done and it's over and people have made up their mind. We still see thousands of Alaskans choose to get vaccinated every week, particularly regions that are being hit hard. We see higher rates of uptake in vaccine. Remember, it takes a bit for the vaccine to really kick in because it's not a therapeutic, it is a vaccine. It teaches your body how to build a strong immune response system so that if you're exposed to the virus, your body knows how to take down the virus quickly, keeping you healthy and well and out of the hospital. So currently 57.4% of those 12 and above have received at least one shot and 52% are fully vaccinated. Again, if you've received one shot, really encourage you to get both shots. Again, with the Delta variant, we're really seeing that both of those shots is way more protective than just one shot. So consider getting both shots and talking to your friends and family. Alaskans trust their friends and family more than anyone else. We are just talking heads on Zoom. You are their friends and family, so consider having a conversation with them. You can see Delta is becoming our predominant variant. We had 137 new Delta variant cases in our last sequencing report. The sequencing data usually is about 2 weeks behind because it takes a while to sequence these. And again, this is an overall situational awareness rather than an individual case by case. And this is a graph that I always like to look at, and it shows you kind of what's the predominant virus overall. And you can just really see we've had this big uptake in the Delta variant in our sequencing data overall. Why does Delta matter? Why are we even talking about it so much? And I think it's because this virus has changed in ways that make it more transmissible. And when you have a virus that's more transmissible, it ultimately kills more people because it moves from person to person more quickly, causes more hospitalizations, and really is harder to slow down. So here's when you're looking at the R0, or kind of that, one person, how many people they can give it to. This is affected by a lot of things, including, if those people are vaccinated, if people are masked, if they're indoors, outdoors. But this is just a way for us to kind of estimate how easily this virus transmits between people. Influenzas may be about 1.3. One person gives it to about 1.5 other people. The original wild type coronavirus that we saw with COVID-19 was about 2.5. And, when we were talking about these exponential graphs, that is what we were looking at that time. But you can see how this virus is changing. And when you got to the alpha, we were seeing an R0 of about 4, 4.5. And now with the delta, we're getting to 5 to 8. So really much more transmissible as a virus. And part of the reason we're seeing these really steep incurves of cases across the state and the country. Just to put it in perspective, that is still less than other diseases like mumps and measles, which are very transmissible diseases overall. So just a little bit more information there. Again, there were some changes to the CDC guidance this week, specifically because of the changes in the Delta variant. And what we continue to see is the vaccines help prevent you from getting severe symptoms, hospitalizations, and deaths. 96% of our hospitalizations and 98% of our deaths are in unvaccinated individuals. The Hospital Association had a press conference yesterday and really talked about the severe strain on the hospitals right now. This is always a time of year when things are very busy in the state. That has been exacerbated by the lack of healthcare workers, as many have left the field, and there's a lot of demand for just workers in general, as I think we all know, from driving to restaurants to the coffee shop to healthcare worker space. And then we're seeing a real surge in cases that is resulting in more hospitalizations, particularly younger individuals. And they are also seeing sicker people in the hospitals, and that's really backing things up in the hospital. So why there was a big ask for people to consider getting vaccinated. So again, vaccinated individuals really helps prevent severe symptoms, hospitalization, and death. So this is part of the reason why we should be concerned about this variant and why they made the recommendations to go ahead and consider masking in the indoor space even if you're vaccinated. The reason is not because vaccines don't work. The vaccines work really well, but just like a seatbelt, seatbelts are best put on beforehand, before the accident. And sometimes you need to have additional protection measures when you're going fast and you're in hazardous conditions. Right now, most of our state is in increasingly hazardous conditions with COVID-19. And so putting on your seatbelt by getting vaccinated and then adding additional levels of protection, such as masking, can help both benefit you as well as those in those areas. So that's why we are asking those in the indoor space to consider masking as well. And so just encouraging people to talk about the vaccines, asking questions about it. People have amazingly great questions about vaccine. You can always request one of our speaker bureaus to come to your community to answer questions. And then they did put a recommendation out to really, help protecting our kids who can't be vaccinated as of yet. Here's some data from Alaska specifically. So again, in Alaska, hospitalizations since January 1st, 97% of our deaths have been in unvaccinated individuals, 3% have been in vaccinated, and same with hospitalizations, 94% of the hospitalizations have been in unvaccinated individuals. So just continuing to share that data overall, so it does really help to minimize this. This data will continue to change over time, particularly as our denominator grows with vaccinated individuals. And as this variant continues to spread across the state, and we'll continue to share that information as we have it. We've also been getting a lot of questions about what does this mean if you're vaccinated or unvaccinated. Biggest thing is if you test positive for COVID-19, regardless if you're vaccinated or unvaccinated, you need to isolate from others so that you don't spread it to others. And that's usually 10 days from the onset of your symptoms or the test, making sure your symptoms are improving and fever-free for 24 hours. If you have no symptoms and you have been exposed to someone who's COVID-19 positive, again, that close contact was within 6 feet for 15 minutes or more, and you're unvaccinated, you really need to quarantine so that you don't spread it to other people. If you're vaccinated, you are much more protected from getting it and from spreading it to other people, but it's not 100%. And so just watch your symptoms for those 14 days. You can consider adding a test between days 5 and 7, but quarantine is not required kind of for a vaccinated individual. And if you've been exposed to COVID-19 and you have any symptoms, again, really getting tested and isolating. But if you are vaccinated, again, and you've tested negative, if you have some symptoms, that really makes it much less likely to be COVID-19 than if you are an unvaccinated individual. And if you have any symptoms of COVID-19 with no known exposures, again, just make sure that you get tested because that helps us to all know what is going on and make sure that we can get treatment to you if needed. Remember, people who are higher risk may qualify for monoclonal antibodies, which is a treatment that's available. And that's another reason to consider getting tested early, is that you could potentially get monoclonal antibodies to help reduce the chance that you'll be hospitalized if you do get COVID-19. Again, COVID vaccines are free and widely accessible across the state. If you're running into any barriers or have other ways that you would like to get it, please feel free to contact us or your local public health clinic. Public health nurses will go home to vaccinate. They've been doing lots of outreach in communities, and oftentimes there's much more vaccine available than people realize overall. I wish we were not at this point to be having this conversation about COVID-19 and the cases. We were just on the call with the hospital CEOs and talking about what that looks like, but we are all in this together, and the more that we can do to vaccinate and move forward, and the quicker we can put this behind us. So with that, let's turn it over to questions.
All right, thanks so much, Dr. Zink. So I know that we touched on this a little bit in your presentation, but I think it's probably worthwhile to address directly. We have somebody asking here, what is the guidance on protection of the Moderna vaccine if they had missed the second shot in their series, and whether or not they should, 6 months out, still get that second shot?
Joe, you want to take that?
Sure, I can start with that. Yeah, so thanks for asking that question. It's a question that's come up, with some frequency, and I know a number of other people are in the same situation. So our strong recommendation is to get that second dose as soon as you're able. One of the things that we found in some of the clinical studies that have been done, epidemiologic studies, for example, one study out of the United Kingdom, showed that people who had only one dose of Pfizer vaccine, and we're assuming that Pfizer and Moderna are going to be pretty similar, they were only about 35% roughly protected against the Delta after one dose of the vaccine. Once they got their second dose and waited the 2 weeks, then that protection went up to 88%. So it's a huge difference. So really strongly recommend getting that second dose as soon as you're able.
All right, thank you so much, Dr. McLaughlin. We also have a question here asking about to what extent might vaccinated, mildly symptomatic people be spreading COVID?
Yeah, I can start with that one. One of the things that we have found is that the viral load, the amount of virus that is in a person's nose and mouth, if they're infected with the Delta strain, is about the same whether they've been unvaccinated and are infected or whether they've been vaccinated and are infected. So the amount of virus in a person's nose, really, once you're infected, it's about the same, unfortunately. That's what we're seeing with the Delta. So we have to assume, until proven otherwise, that anybody who's infected, regardless of their vaccination status, they're capable of transmitting the virus to others. Now, one of the positives that we've seen so far in some of the early epidemiologic studies is that people who do have what we call a breakthrough infection, so they've been vaccinated, but they get infected with the Delta strain, is that they tend to have milder symptoms, which could be, for example, less coughing. And the less a person who's infected is coughing, the less they're actually, spewing the virus into the air. So that can help reduce transmission compared to somebody who maybe didn't get vaccinated and is infected and is coughing more.
I think I just want to emphasize that has been a change with the Delta variant than the wild type. And so again, the change in recommendation came because this virus has changed. And so when we saw the wild type, we were not seeing much viral load at all in vaccine breakthrough cases. And unfortunately, we are seeing it now with the Delta variant.
And one of the things I just want to underscore, and maybe Aaron, if you can allow me to share my screen. It looks like I have that. Okay. I wanted to just show, these are some graphics that I kind of pulled out from some studies that we're probably going to be presenting tomorrow on the healthcare provider Echo. One is the cycle thresholds for values for unvaccinated persons. Here you've got in the pink, the Delta variant, And here in the blue, you've got the 19A, 19B variant, so different variants. So with the Delta variant, you have what we call a lower cycle threshold value, which translates to higher concentration of virus in your body. So the lower the cycle threshold, the higher the viral load. So what we're seeing on average is a much lower CT value among people who have the Delta variant compared to other strains. And that translates to a higher viral load. And then here's the other one that I was just referring to, which is cycle threshold values in unvaccinated people versus vaccinated people who have the Delta infection. And what you can see is that those cycle threshold values are pretty similar, maybe just a little bit higher in the vaccinated population, but not statistically significantly different. And they're quite low in the sort of low 20, the average is sort of low 20 range. So that translates to a very high viral load. So again, really underscoring the importance of doing whatever we can in Alaska as quickly as we can to decrease transmission of this virus. And the number one way to do that is to get vaccinated.
So Joe, there's a question a little bit later about the efficacy of vaccines against the Delta variant. So would you mind just commenting on that to put that in perspective about like no vaccine versus what we have in that?
Yeah, and this is something we went over last week as well. So remember that when the original clinical studies were done, clinical trials were done on the Pfizer vaccine and the Moderna vaccine, what we found is that those vaccines were about 94 to 95% effective at preventing infection in people in COVID, actually not infection, but COVID illness in people who were infected with the strains that were circulating at the time. And remember that this was pre-Delta and this was pre-Alpha. Now, the more recent studies for the Pfizer vaccine have shown that the efficacy has dropped a little bit from about 95% down to about 88% based on the current available science and data. Now that could change. I mean, this is always changing. It's always fluid, but that's kind of roughly what we're seeing so far with the studies. So what does that mean? So that means that if 100 people are vaccinated, fully vaccinated with, let's just say, the Pfizer vaccine or the Moderna vaccine, we would expect that if all 100 of those people are exposed to the Delta virus, then about 12 will get infected and will actually have COVID, 12 out of 100. And if you're talking about the Johnson & Johnson vaccine, we don't have good studies yet for J&J, but we have pretty good studies for the AstraZeneca, which is roughly equivalent. Then the vaccine efficacy drops down to probably in the sort of mid to high 60 range. So that means if 100 people are vaccinated with the Johnson & Johnson, or let's say the AstraZeneca vaccine, and you expose all 100 of those people to the Delta variant, then you would expect that about 33 roughly will wind up getting COVID illness. Now, among those people who get infected with what we call a breakthrough infection, the vast majority are going to be, are not going to require hospitalization, and much fewer of those people would require hospitalization or die than people who are unvaccinated and get infected. So, and just kind of reminder from last week, if you take 100 people who haven't been vaccinated at all and haven't had prior SARS-CoV-2 infection, all 100 are expected to get infected and get infected with the virus. So hopefully that provides a little bit better perspective for folks. Thanks.
Okay, thank you so much, Dr. McLaughlin. Building off of your comments about hospitalization rates, we do have a couple questions that wanted some clarity. Earlier in our session, Dr. Zink, you'd mentioned the rates of folks who've received the vaccine still getting hospitalized with COVID. And we had some questions asking how current that data is, and if there is data that can be separated out specifically for the last few weeks, and just wanting to understand a little bit more clearly, especially with the Delta variant, what the risk is for folks who are vaccinated and being hospitalized if they contract COVID.
Yeah, I appreciate the question. And I do want to apologize because I was speaking based on the last time I'd seen the data, but the team does a great job putting these emails together with most recent data, which had been updated. So by the time I got to that slide, it had been updated. So that is the reason for my misspeak on that. So the team is always updating data in real time, and sometimes it happens on our press conference. But Louisa, maybe you could speak to hospitalizations, cases, what we're seeing, kind of trends along those lines, the challenges of getting it out, and the trends over the last couple of months.
Sure, we are putting in the weekly report kind of an update by week of data that's kind of come in, and that's, you know, the number of cases, the number of vaccine breakthroughs that are associated with the death, associated with the hospitalization, and sort of the proportions of that from January 1st forward. And so that's coming out on a weekly basis. It's a little tricky sometimes to kind of track this real time. We know that some people develop signs of COVID, get tested, do okay, go home, and then maybe are hospitalized, you know, a week or so later on. And so it's not sort of this immediate thing that necessarily happens for all people. And that's why it does take a little bit of time to sort of follow that trend. The information that's on the cases website is for people who've ever been hospitalized with COVID. And so that is not the same as looking at like the current capacity at a hospital right now and what proportion of people are kind of being managed for COVID and for other things. But that kind of weekly update of those figures come in that weekly report, and probably Elizabeth or somebody could put the link out to where you can find that on the website. It's that weekly summary that comes out sort of Wednesday-ish or Tuesday-ish, Thursday-ish, something like that.
I would just emphasize too to put these things into context. So I, sometimes get like direct messages or emails that say, well, this week there was 100% increase in deaths or hospitalizations. But when we have small numbers, you're going to get a lot more, as Louisa says, like wiggle in the data. And that's why it's better to look at the overall trends of what we're seeing with hospitalizations and deaths. And also looking at national data. So not just looking at our state, but when you're able to get a lot of people into a group of, understanding of hospitalizations and deaths, that will help us to understand the overall trends rather than the individual data. So we get a lot of wiggle when we look at really small data points. So use those weekly ones with caution. Try to look at a little bit larger trends than that, or more people.
All right, thank you so much, Hub team. A question building off of what we were just discussing. Is there a reason why this data on breakthrough cases isn't included on the dashboard? And is that something that is being considered?
Hey, Louisa, you want to take that one on?
Sure. Again, it's not something that is instantaneously known at the time. And so because those numbers are small and because it takes a little time to compile them, its value really is in kind of giving that statewide picture. We're always evolving our data presentations and trying to put together meaningful, sort of meaningful formats for people to help direct, sort of direct actions. But that's currently how we're putting it out there. There's information about vaccine breakthroughs in the genomics report each week, and it's also in that weekly summary. And then we do have some bulletins that we've put out and a process whereby we can update that also on a monthly basis. So trying to get that information out there as things are evolving.
And just one other thing to add to that. So the dashboard takes like the cases that are in and like kind of, puts them in real time, but there isn't a way to kind of like analyze it and to put a bigger perspective on it. And so that's why these bulletins or newsletters can be more helpful. Again, like vaccine and who's vaccinated or not, that may take a contact tracer to ask that question. They may have been vaccinated to like the DOD or VA or out of state, and that wouldn't be in our information immediately. So it's not like we have some magic database that just like cross-references these things all the time and can put them up. It takes like manual, like calling the patient, having these conversations with them. And as Louisa mentioned, sometimes, someone gets hospitalized later or more information comes out. And it's for those reasons we try to put on the data dashboard the things that are most easy to just put up on a regular basis that are clean, and things that take more time and processing to be able to get the full picture in these weekly summaries or in these bulletins where you can get the whole picture because it isn't immediately available when we get that case in.
All right, thank you so much, Dr. Zink. So we have a comment here actually from somebody who works in contact tracing, and they're sharing that they're observing that now that they're reaching routinely contacts at 8 or 9 days after exposure to cases, because folks who have been vaccinated are taking longer to recognize their symptoms and to make the decision to test. This person was wondering if, well, basically this delayed exposure to test cycle seems to be a significant factor in the exponential spread growth. And they wanted to know if folks were looking into options to notify people when vaccinated as to this dynamic and how to manage quickly and effectively potential exposure and a positive COVID.
Aaron, yeah, really appreciate that question from the questioner, and the contact tracers are amazing, and they've been doing this now for so long, and really just hats off to all of you who are on this call who are contact tracers and for all the amazing work that you're doing. Really appreciate this feedback. You know, one of the things that's particularly, again, another thing that's particularly concerning about this Delta variant is that the pace of infection in terms of viral load is changing. And what we're seeing is the incubation period for this virus appears to be quicker. Here in the blue or green, whatever color that is, teal, is the 2020 epidemic, and here's the 2021 epidemic. And again, the 2021 epidemic is largely driven by Delta now. But what you can see here is this is time from infection to the first PCR positive test. And you can see that we've gone from about just shy of 6 days during the 2020 pandemic to now just shy of 4 days. And so what we're hearing from the scientists who are really studying this closely is that the incubation period for the Delta variant appears to be much faster, probably on the order of 2 days faster than previous strains. And so that really underscores the importance of, as soon as you have any signs or symptoms of illness, no matter whether or not you're vaccinated, to please go in and get tested. The sooner you get tested, the quicker we can do contact tracing and get other people notified and, you know, appropriately in quarantine.
Hey, this is Louisa. I mean, one other thing,
Dr. McLaughlin.
Sorry, I was just going to add one other thing. You know, with the information that CDC was putting out yesterday, there are some other recommendations for vaccinated people to maybe consider getting tested right after an exposure. And that's something that wasn't necessarily a recommendation pre-Delta. And so we're updating our testing guidance. And that's something that, you know, for sure at the first sign of symptoms get tested. But now I think maybe we're going to be encouraging, you know, a lot more testing of those people who have had exposures just to catch something, you know, even earlier, you know, buy us another day as well. So be looking for that updated guidance.
Yeah, that's a really important point. Thanks, Louisa. So the new CDC guidance basically says if you're fully vaccinated and you know that you had close contact with a confirmed case, then please get tested between day 3 and 5. And in the past, we'd say get tested if you were in quarantine between day 5 and 7. But now, because everything's kind of speeding up with this Delta, for folks who are fully vaccinated, we want them to get tested between day 3 and 5 if they've had a known close contact exposure to a confirmed case. They still don't need to be in quarantine if they're fully vaccinated, but we do want them to get tested. And then if they test positive or if they develop symptoms, they need to go into isolation.
Aaron, you're still on mute.
Thank you. All right. Thank you so much, Hub team. Building on that, we have a couple questions asking about the efficacy of different types of tests. Could members of our Hub team speak to how accurate the results of the PCR test are and versus other types of testing?
So I can start. I'll mention that there's lots of different types of tests. So we have rapid molecular tests. Molecular tests look for the genetic material of the virus. There's rapid PCRs. There's lab PCRs that take longer. There's rapid antigens that look for the surface proteins. Those are what we consider diagnostic tests. So those will be a swab of the nose or mouth or saliva. Those are looking for the virus. When you test positive on any of those, it's pretty likely that you're positive. You know, on the molecular tests, rapid or send to lab, it's extremely unlikely that a positive isn't a true positive. You know, for people who test positive and then negative, it's it's way more likely the positive is real and the negative is false than the other way around. For antigen tests, you know, they look for surface proteins. They do require a little bit more virus, but they're also very good tests, especially when done for screening purposes often. You know, a lot of places are using those kind of, you know, every few days, once a week, twice a week, something like that for screening. I don't know, Jamie, do you have anything else to add on the, I guess, to summarize lab testing?
No, we don't. We were just talking about limit of detection in here, and if you were to do a rapid molecular, which one would be the go-to? They're all pretty great. I have nothing more to add. Thanks.
In our state, I will say in our state testing guidance, we just use the term molecular because some of the non-PCR molecular tests perform better than PCR tests. So there's just a lot of variability, but with pretty much all of them, you know, a positive is a positive.
I was just going to add, remember that there's testing available, including rapid testing outside of the security area. And so if you've, you know, recently been on a trip, you've been exposed to someone with COVID-19, there is lots of ways to get tested. And there is also antigen testing available at some of the pharmacies and Walgreens, Walmart places that you can just purchase yourself, and at home PCR testing that you can purchase. So lots of options for you to make sure you and your family stay safe.
And Teresa, I think there's another question about this, and I've gotten a lot of questions about the misinformation that the CDC, there's an internet myth that the CDC is not going to recommend PCRs after the end of the year, but really what that is the CDC is no longer making their assay, because for PCRs, there's a whole lot of assays, and basically that's the chemicals in the platform you use. The CDC produced an assay that early on in the pandemic, and they're not going to be making it anymore. So that's more of a call. If you're using their assay, get a different one, not to say we should stop using PCRs. I don't know, Teresa, would you have anything to add to that?
Yeah, no, we agree with what you said there, Coleman. The CDC is going to discontinue their emergency use authorization because there are enough established PCR tests that they don't need to support it anymore. Thank you.
All right, thank you so much, Hub team. Building off of that, are there any recommendations for specific types of tests for a shared or communal living facility?
We do have some guidance on this in our state testing guidance. You know, you can use antigen, you can use molecular, but it really comes down to the limitations of the test. I'll put our state testing guidance in chat because we have a nice flow chart there to help you determine which test to use when.
All right, and could our Hub team also address a comment here asking about why might it be if somebody is actually indeed has COVID, why they might test positive or test negative at first?
Over, Joe.
Okay, sure. Yeah, so basically what happens is, let's say I'm infected with, let's just say the Delta variant, and let's just pretend, we know that Dr. Zink is vaccinated, but let's pretend that she's not vaccinated and she hasn't been exposed to the virus in the past. And I cough right on her today. It's gonna take her, and she gets infected. So it's gonna take some time before she has enough virus in her system to trigger a positive test. And with the Delta, again, as we said, it's going to be faster than it was for the previous strains for her to develop a high viral load. So what might have taken 5 days or 4 days for her to test positive, now it might only take about 3 days for her to test positive. But during that first day or two after exposure, she probably won't test positive yet because she doesn't have enough virus in her system. The virus hasn't replicated enough in her system to trigger a positive test. And then conversely, of course, you know, the viral load is going to go down over time. So you get infected, it peaks, you know, and let's say it peaks at day 3 or 4, maybe 5, and then it starts coming down. And then on the tail end, let's say you test somebody sort of as they're going down, they test positive initially, and then a day later you test them again, they could be negative because that viral load has dipped below that, that threshold of detection.
All right, thank you so much, Dr. McLaughlin. So we have a couple questions here asking about folks who've already received the J&J vaccine, perhaps thinking it might be beneficial to receive a Moderna or Pfizer vaccine. Any guidance on that?
Great question, Matt. You want to take that one on?
So I have been on vacation, so if I'm not up to date on this, please let me know. But to my knowledge, there hasn't been any studies recommending a booster for the J&J vaccine. Am I correct on that?
Yep, you're correct, Matt. So yeah, the Advisory Committee on Immunization Practices has not recommended people, for example, who have had the J&J vaccine to go ahead now and get an mRNA vaccine, because we know the vaccine effectiveness is higher, especially against preventing just routine COVID or COVID infection. Now, in terms of the effectiveness at preventing hospitalization and death, they're much closer. We think that the mRNA vaccines are probably well above 90% effective, probably in the mid 90% effectiveness at preventing hospitalization, even with the Delta. Whereas the Johnson & Johnson probably is closer to that, but maybe in the 80s, mid to high 80% range. Again, this is just preliminary data. We don't really have great epidemiologic data yet on the Delta variant, but as we get more information, we'll let you know. So the short answer is, at this time, there is no recommendation for folks to get what we call a booster dose or a second dose of the vaccine, or an additional dose of the vaccine from another company, for example.
Then I'll just add, because there's questions coming there, that's the same with a third dose. So right now there's no recommendation for a third dose. If you got the mRNA, the ACIP looked at that last week. We are seeing some preliminary data, particularly in patients with solid organ transplant, that a third dose can increase their antibody response, which, in those sorts of conversations are driving the conversation about, does a third dose, is it needed? How about people who are regularly exposed, like healthcare workers? And are we seeing waning immunity at not? And then, as Joe mentioned, kind of crossing between different vaccine types. And there's a lot of international studies going on in this space right now. But for right now, we just really need to follow the EUA, stick with what has been recommended with the 3 different vaccines that are out here, the Moderna, the Pfizer, or the J&J vaccine. But again, if you're a high-risk individual, consider personal protective gear, masking up, taking additional precautions while we have a lot of cases right now to help protect yourself in the setting of a rapidly spreading virus.
All right, thank you so much, Hub team. And then just to reiterate, I know that we touched on this a couple of times, but I do see questions continuing to come in about boosters for the other vaccines, Moderna and Pfizer, and whether or not they're recommended currently.
Not at this time.
Yeah, not at this time. We just didn't address that one.
Excellent, thank you so much. Let's see here. We have some more questions related to hospitalization, in particular age groups. A comment here from Faz saying that hospitals say COVID patients are both younger and sicker than before. Last year, younger people drove up case counts, but not hospital rates. What are they experiencing? Why are they experiencing more severe disease now?
So I can throw in a couple things, but I think the whole team's got a little bit to add here. So we did look at our average case that was hospitalized last November versus now. So last November, the average hospitalization was 63, and at this peak here, more recently, it was 56. So, we saw an 8-year age drop in that. We see similar ages in our cases. So last year, the average case was 36 years old versus this year it's 37 years old. So really not a big difference in the cases, but a difference in the hospitalizations, a younger group being hospitalized. Regarding people being sicker, it's a great question. We have a harder time seeing that in length of stay and kind of the acuity level from the state perspective, but the hospitals are sharing that information very regularly, that they're seeing younger people and people being sicker. There may be a series of reasons for that. People presenting later in their disease process. Again, I think there's a lot of people who don't know that monoclonal antibodies are available if they test positive and they're high risk. And so encourage people to consider that, because there is data to show that it can minimize your chance of being hospitalized. Overall, our older population is more vaccinated than our younger population. So I think we're seeing younger people for that reason. Younger people's bodies can usually fight longer. So they have longer hospital stays just because they otherwise are healthy and don't have some of the other aspects. Regarding if this variant is more virulent or causes more severe disease, I think the data is still out on that. We don't have a good understanding of that at this time. Some data suggests yes, some data suggests no, and we're continuing to follow that closely. But Louisa, Joe, other things that you would add on that topic?
Yeah, you know, one thing I can do is just show what's happening with cases. So this is cases by week and age group in Alaska, and you can see, I'll drop down to the legend here. So the 20 to 39 year age group, and this is throughout the pandemic now, you can see the 20 to 39 year age group has basically been in usually #1 position in terms of case counts, and they still are. So really, gosh, we need to do whatever we can, folks. If you have friends, kids, family members, colleagues, whatever, in this age group and they're not vaccinated, please help nudge them towards you know, talking to their healthcare provider if they don't feel like they have enough information about vaccination. We really need to get these folks vaccinated because they continue to drive the pandemic.
All right, thank you so much, team. We have a question here regarding data around breakthrough cases by age. Is that something that is also included in the weekly update reports?
Yeah, Louisa, you want to share that?
Yeah, not by age. I think in the bulletin, you could see the information by age. I think we gave a median age and a range there, but you know, some of that, and for much of the vaccine breakthrough data, you know, it's based on people who are vaccinated. So we have more people who are vaccinated in higher age groups. And so some of these things, you know, you can find that data point, but it really needs the context of who all's been vaccinated, who all's recommended for testing. But that's something that we can look at, you know, going forward. As I said, you know, we're evolving how we present our data. And I think, you know, people have asked us questions as well. Well, what about the different formulations? You know, can you tell us how many of each different formulation? And that again is so differentially, you know, people have been vaccinated. There's different amounts of those vaccines that have been given out in the state. And so to give you kind of a raw number on those really reflects the distribution of vaccination and not necessarily one product over the other. So, but as I mentioned, you know, we are sort of evolving how to present this data more regularly for folks.
Thank you, Dr. Castrodale. A question here also related to data and reporting. Is it possible for folks to be able to identify whether or not they have the Delta variant if they do test positive for COVID?
Great question. Short answer is no. But Teresa and Michael, do you guys want to go into that, or do you want us to cover it? We get that question a lot.
We've been like trying to research that ourselves, and the types of symptoms for Delta variant, even in vaccinated people, is on such a wide scale that I don't have an effective answer. But
yeah, and the other thing is sequencing takes a while. So it takes on average about 2 weeks from the time we get a positive sample in time it's sequenced. It takes at least 4 days on the machine, and it's not what we call a CLIA certified test. And so we can't give line level data back. So there's no like little solution we put it in and it says it's Delta and we get that back right away. It takes weeks for that to come back, and we can't provide that kind of line level data. What we do provide is community information. And again, take a look at that sequencing genomics report that the team puts out once a week, which is fantastic. And it talks about regions. Sequencing is really meant to look overall at the trends that we are seeing rather than individual cases. And so that's why it's important to take a look at the overall trends rather than individual cases on that answer. So that's why we can't provide line level. And like Teresa said, symptoms are pretty darn similar. So get tested.
All right. A question here from somebody who works at a NICU, and they expressed concern about the number of unvaccinated parents in the NICU, especially with this new spike. They're hearing a lot of myths that the vaccine causes infertility, contains a microchip, etc. And they were wondering if there were brochures available and other resources to help combat that misinformation and to also encourage folks to stay safe and reduce the spread.
I really appreciate this NICU nurse bringing this up. I think that healthcare workers play a really important role in helping to share information and ask and answer really important questions that friends and family have. Elizabeth, where would the NICU go to if they want to take a look at some of the handouts that have been made and be able to share that information?
Yeah, it's a little hard with our website down, but we do have some things on there. I'll put some places in the chat box where they can find things, and they can always email us if they are looking for something. We're happy to try to get those items over to you.
I will also say a lot of our information and graphics comes from suggestions from you all as well. And so, you know, happy to always relook at those things and provide tools and resources for you to provide it to your patients so that they can protect themselves and their family.
All right, thank you so much, team. We have some questions here related to so for folks who have underlying conditions or are, let's see, I'll just go ahead and share this one and it reflects quite a few other questions as well. All right, so this person asks, what would the vaccination status be of people who've done immunosuppressive or anti-CD20 therapies like Rituxan? Studies have shown that these therapies can lead to dramatically and durably blunted humoral response with regard to vaccination. Should people who have done this treatment post-vaccination be vaccinated again?
Yes, it's a great question. We always recommend talking to your primary care provider or what that looks like. Immunosuppressive medication are incredibly varied and have very different responses, and different people respond to those medications very differently. As mentioned, some people have prolonged or even lifelong blunted immune response systems, and some people have very little. So in general, the best thing you can do is to get 2 doses of mRNA vaccine to protect yourself. At this time, no recommendation for a 3rd dose. But if your primary care provider, oncologist, rheumatologist, whoever's managing your immunosuppressive medication thinks that your immune system is suppressed, adding additional protective layers, such as making sure you're going outside, masking, distancing, those things can make a difference to help to protect you as well. So I would highly encourage you, particularly in the surge, to talk to your primary care provider about that, because not everyone's immune system is the same, and want to keep you safe.
All right, thank you so much. So we have some questions here regarding masking and other measures, and if there's presently any guidance on a state level with the administration as to enforcing any or asking for mandates related to masking and social distancing. Are there any updates in regards to that with the increase in COVID cases?
Yeah, so we are a home rule state. And so really that authority very much relies in local municipalities, tribes, and regions. We do get asked a lot to come to different councils and community councils to have a discussion about what we're seeing locally. We no longer have a state disaster declaration in place, and as a result, there's no authority from the state government in that space. And so what we do is we share the same information that we're sharing here with you to your local leaders, to municipalities, and to others, and encourage people to consider masking, particularly in indoor spaces while we're in high transmission levels. It is, again, an effective tool to minimizing COVID-19. It does not mean that vaccines don't work. Vaccines are our ticket out of this pandemic, but while we are in a high risk zone, adding masking can be an effective tool, and that is really decided at a local level and an individual level.
And this is Joe. I'll just add, as Dr. Zink showed on the original slides that she reviewed, we're in a rapid acceleration phase right now. And so most of this is being driven by people who are unvaccinated, the vast majority. But we are seeing some breakthrough cases in people who have been vaccinated as well, as expected. And we talked about why that is. So what else works? Number one, we need to get everybody who is unvaccinated to please strongly consider getting vaccinated. If you have questions, talk to your provider. Number two, what else works? We know that masking works to help decrease transmission. We know that social distancing helps to decrease transmission. We know avoiding crowds works to help decrease transmission. So these are all layers that we can add to help slow down the spread of this virus. So what's happening right now in this rapid acceleration phase is, if we were to magically get every Alaskan vaccinated tomorrow, we would still see a rapid acceleration for a while until those folks become immune. So between now and when we peak and start going down, we need people to just do what we know works to help prevent transmission. Masking, social distancing, avoiding crowds, all that can help prevent this rapid acceleration, slow it down, and ultimately bend it back down. And as Dr. Zink mentioned, our hospitals are getting taxed. Many of them are getting full, not just with COVID patients, but with all sorts of patients. Summer is a busy time for hospitals. And so we need to do whatever we can to help decrease the COVID-19 contribution to hospitalizations in Alaska. And so hopefully that helps answer that question.
I'll just build on the hospitalization part because I see another question in there. We are seeing elective procedures canceled at many Anchorage hospitals, Alaska Regional, Providence Hospital, and ANMC currently at this time because of the inability to have any sort of beds. We are also seeing delays in transports. And again, like we talked about at the beginning of the pandemic, when we start to get hospital systems overwhelmed, it impacts all sorts of levels of care, be it a trauma and you fall off your bike, or be it, you're having a heart attack. We want people to get access to care. We want people to be able to have a hospital if they need it. But to do that, we need space and availability. And because we don't have the staffing that we had before, summers are always a busy time, like Joe mentioned. Alaskans are having a lot of fun out there. Please be safe. Put your helmet on, drive the speed limit, wear your life jacket if you're on the lake. You may not have a bed available in a hospital at this time or have to wait for really long periods of time. And it's really heartbreaking as a clinician seeing patients on the front line and being like, I have nowhere I can transfer you to right now. So please consider vaccinating, taking care of your health, be safe, be careful right now. It's a rough time in the hospitals.
Erin, I would like to show, I know we're almost out of time. I want to show this one other graphic. I think it helps kind of really explain what's happening with the Delta variant. So this is secondary infections in unvaccinated people. This comes from Health England in one of their technical briefings. The dotted line represents non-household members. So dotted is non-household, and then solid line is household. Pink is alpha, and blue or gray, whatever that is delta. So let's look at the dotted lines first. Non-household transmission. This is the secondary attack rate. So among people who are infected, how many other people are they going to infect? It's sort of this, that's what we call the secondary attack rate if they're around them. You can see that for Delta, the secondary attack rate is much higher than for Alpha in non-household members. But now look at it for household members. These are the solid lines. Look at the difference here in household members. It's a big difference in secondary attack rates. So just another way of showing how transmissible, how much more transmissible this Delta variant is than previous strains.
And so what that translates to is a whole family ending up sick and multiple family members being hospitalized. This came up on our CEO call today. Like, how come we're seeing whole family members being hospitalized? And it's just for that reason that Joe mentioned, and that can be devastating to that family.
All right, thank you so much. I know we are ending, or we're nearing the time to conclude. However, I do see a question here that's pretty important. Somebody is asking if public health is able to drop off tests, or what testing options are available to those people who aren't actually able to get out to a testing site. What resources are available?
Yeah, so Coleman, feel free to jump in. You can purchase testing right now, Walgreens, Walmart, and I had some. My daughter had developed a stuffy nose and it was super easy and I did it right at home. So you can go buy some right now and have them at your house. You can order PCR tests at home that you can then send in. So I think you never know when you're gonna get sick. No one really plans on it. So having that easy and accessible, It's very safe from a COVID perspective to drive through a drive-through testing site as well. And again, if you've got someone who's COVID positive, you can't do that, like we get that. So take a look at that. And then, you know, some communities touch base with your local community health aide and or public health center because they may be able to as well. It really depends on the community overall. Coleman or others?
Yeah, I think the best option, I mean, there are direct to consumer ones that you can get online, order them, they ship a box to your house, you swab yourself, you ship it to lab. We did some test runs of those, and I mean, you can have results in 2 to 3 days from the time you hit click. So including shipping both ways, that's, you know, really for Anchorage, Fairbanks, you know, Kenai, kind of metropolitan areas, those are a really good option.
All right, thank you so much. So it is 1:01, so I'm going to go ahead and ask if there are any updates from our hub team.
Just appreciate you guys all coming on. Sorry we didn't get through all the questions. We'll try to go faster next time. We really love that you guys come here.
Yes, all right. Well, thank you everyone for joining us. And just a reminder that this session, the Public Health Science Echo, occurs every Wednesday from 12 to 1, and our next session will be August 4th. Also, just a reminder to please go ahead and visit the shared box folder to access videos and slides from all echoes in this project, including today's session. Again, I just want to echo our hub team's thanks for your participation. You really make this all happen. So lots of gratitude, and we will see you next week. Take care, everyone.
Thanks, everyone. Bye-bye now.